Thank you very much. First of all, thank you so much for the organizing committee for having me. I have to say, it was probably the quickest exit from an airport I've ever had into my hotel this morning. And thank you all for having me today to speak to you about advanced renal cell cancer. My name is Raj Nair. I'm one of the urology consultants at Guy's and St Thomas's Hospital and HCA. And this is where I work, very grey part of London, but luckily I'm in that nice tall building there. So it's nice to see some sunshine here. And this is actually a Kuwaiti patient, and I thought I'd start with this slide because this is a patient that we treated about a year ago from Kuwait with a massive renal tumor. And these are difficult. These are difficult operations. They test you, they tire you, and they wear you out, but they can be done. And that's what I want to try and talk to you about. When we talk about locally advanced renal cell cancer, we're talking about tumors which are basically T3 or T4. You know, about 25% of patients will present with these kind of tumors, and they extend into major veins. They directly involve the adrenal gland. They can extend beyond the perirenal fat into other organs and beyond Gerota's fascia. So automatically, these tumors are higher risk, as you can already tell. And the cancer-specific survivals get worse and worse and worse as the T stage gets larger. You can see you drop from 80 to 96% survival rate from a T1 tumor all the way down to 25% 10-year survival rates with T3 tumors, and even worse with T4 tumors. So when you're dealing with an advanced renal tumor, survival has to be part of this whole equation. And there are certain things that make survival, prognostic factors that make the survival factors worse. Clear cell subtype is worse. Higher Ferman grade, sarcomatoid differentiation, perinephric fat involvement, lymph node metastasis is definitely worse, and lymph node metastasis is worse than renal vein metastases, renal vein extensions, and distant metastasis obviously puts you in a very poor group. And you can see these are the kind of tumors that we're dealing with. But what I don't want you to forget is that there are T3 tumors which can be small renal masses, but they will still behave badly because they're involving hilar soft tissue, right central, very central tumors, and you're going to hear a lot more about that in a second as well. Whenever we're managing kidney cancer, and this goes across the whole board of kidney cancer or anything to do with the kidney, you've got to think about the tumor characteristics, what function those kidneys have, and what are the patient's characteristics that you're dealing with. And what I'm here is not to tell you by verbatim from a textbook how to manage advanced kidney cancer, but I'm going to give you some advice, 10 of my top tips in managing kidney cancer and advanced kidney cancer that I've learned over the last few years, and also having worked with very, very experienced surgeons in London who have learned these things as well. The first thing goes without saying, plan your case well. Know exactly what you're dealing with before you go into those operations, because there can be some seriously catastrophic blood loss if you don't do it. You need to know exactly what level tumor thrombus goes up to, where the nodes are and whether you're doing a node dissection, what organs are infected, do you need to bring in other specialties, and the size of the tumor. You need to know exactly how many renal arteries are there. That is probably one of the biggest things that you need to know before the case starts, because you need to tie off these renal arteries early in order to avoid blood loss. How much IVC occlusion is there? And you can tell that because if the patient comes to your clinic room with tree trunk legs and they're barely struggling to come in, you know they've got high-grade venous obstruction. And we tend to use multiple modes of imaging to try and decipher exactly how high that tumor thrombus goes. Does it stop just at the level of the renal vein? Does it go higher than, does it go just below the liver? Is it going up beyond the liver or even into the heart? The worst thing you can do is get caught trying to do a level 2 or level 3 thrombus and then intraoperatively find that it's going well above the diaphragm. You have very little bailout strategy there, and you're going to do the patient a serious disservice. So imaging is very important. We tend to try, if we're not sure, we'll get an MRI scan as well, an MR venogram, just to know exactly how high these venous thrombuses go. Number 2, tie the renal artery early. Get your renal artery sorted early. If you can do that, you will definitely avoid a lot of blood loss that comes handling collaterals that are right around those kidneys. There are big snake-like collaterals around these kidneys. As soon as you pop one, and if the renal artery is going, it's hosing out as a high-pressure system. These are difficult. And so what we tend to do is, you can see there on the, what we do is we tend to, if it's a right-sided renal tumor, we'll go medial to, we'll go in between the aorta cable groove, find the renal artery as it comes off the aorta and tie it there underneath the left renal vein. If it's on the left side, we'll find the edge of the aorta, come right the way up, and then tie the renal artery off at the level of the aorta. If you have enough aortic experience, or most surgeons are very fearful of the aorta. They try and stay away from it. Stay on the aorta. It's your friend. It'll get you to the renal artery. If you tie off the renal artery, it's your first step, and that's always the first step in our operations now. First 10, 15 minutes, just feel the field, try and get onto the aorta, onto the renal artery, tie it off, and then all your peripheral dissection will be slightly less hairy. And we've shown that we've lost, we improve our blood loss by about 1,500 mils by doing that. Be aware of these gonadals and lumbers. They're going to be big tree trunk structures. You put a hole in them, they're very difficult to fix. And it always starts from the first incision. People often ask, do I do routine renal artery embolization? The honest truth is, yes, we do, but as we've gotten better and better with the aortic dissection, the less we need to embolize preoperatively. Because we know it takes 15 minutes for us to get onto the aorta, find the renal artery, and tie it. So we really save the renal artery embolization for very, very difficult left-sided cases. And again, the reason for that is sometimes you don't know if they've embolized correctly. You're not in charge of that procedure. You don't know what's happened. You can assume that things have been embolized properly. There might be another artery. You never know. But certainly the evidence shows that it's fine. You can do it. It doesn't change your cancer-specific mortality in any way. And it starts from that first incision because of these. People with blocked renal veins and blocked IVCs will throw out collaterals, and they'll throw out collaterals right across their abdominal wall. They have big, what we call fairy light signs right across their abdominal wall. So as soon as you start making that cut, you can cut through a very high-pressure venous system. So it all starts from the first incision. These are sometimes some of the things that we see, and already you think, oh my goodness, how am I going to do this nephrectomy? Number 3, be a multidisciplinary surgeon. Learning surgical techniques from other disciplines helps you. Working with other disciplines helps you improve your technique. So what I think is very important is understanding how to mobilize the liver. How do you rotate the liver laterally to medially to expose the intrahepatic IVC? And there is a technique to doing these things. And if you work with liver surgeons enough, or you work with transplant surgeons enough, you'll get to learn these techniques, and you will then take it into your own practice. The same with splenectomy. Upper pole left-sided tumors involving the spleen. You may just have to do a splenectomy, and you know how to do it, or do you have to call somebody else? Hepatobiliary, tail of pancreas. Some tumors invade the tail of pancreas. Can you get a stapler out, fire it across the tail of pancreas confidently, oversew it with some proline, so that you know that you won't get a leak? You need to be a master of vascular surgery, and you do need to understand how cardiac surgery works, because you are going to be working with the cardiac surgeons for some of these level 4 tumors. And you're in charge of that case, because it's your patient, it's your disease. They're just the technicians to help you get this tumor out. So you can't rely on them. They have to work with you as well. So it's very important, these things. Here's the tail of pancreas, which is necrosed after a complex nephrectomy. And this is us going back in to deal with a complication of necrotic pancreas. But how many tumors really do invade other organs? Well, actually, not, more than you think. With locally advanced T3 and T4 tumors, about 9.1% have local invasion. And it can vary to about 15%. But the fact is, if they are involving other organs, your 5-year survival drops quite significantly. So you do need to tackle things with radical en-bloc excision, and MDT involvement is critical. You can't go into these operations knowing that the tail of pancreas is involved and not having another surgeon on standby just to help you in case something goes wrong. So these things are very important. It's very critical to have colorectal surgeons, hepatobiliary surgeons, thoracic surgeons, cardiac surgeons, and vascular surgeons, all as part of your group of go-to people if things happen in these operations. What they hate is to be called last minute. And here's an example of a total pancreatectomy that needed to be done alongside a right-sided nephrectomy. So it's a right-sided nephrectomy of Whipple's as well. There are a lot of lessons that we can learn from the venous involvement cases because they are really ones that test you as a surgeon. So IVC extension is very unique to renal cell carcinoma. It happens in about 4 to 15% of people, and aggressive resection is good because it can cure people. If you have lymph node disease that's positive, the survival rates drop. If you have vascular disease only, actually you do well. So you've got to do it. You've got to do it well. So tumors that are confined to the kidney and free-floating thrombi are better outcomes. So the soft tumor thrombus within the IVC is better than fat invasion. So actually, these people with tumor in the veins, don't be scared of them. Do a very good surgical operation for them. And sometimes you can get caught short because you don't know how stuck that tumor thrombus is to the IVC. And it may involve caval excision. Anyway, here are some examples of some thrombi. So just nice surgical pictures. We're all surgeons. We all like these kind of pictures. So this is a level 1 tumor thrombus going just into the IVC there. Here's a level 2 or 3. And here we go, tumor thrombus going right up to the infrahepatic IVC. And this is what I mean about, are you able to roll this liver right across so that you can see the IVC going right the way up to the cross of the diaphragm and then sealing it there. And in this example, the IVC, the lateral wall of the IVC had to be excised because tumors stuck to it, and we perform a graft, we perform a grafting procedure onto that side of that IVC in order to restore flow. But this requires a lot of patience and attention, and they are challenging cases. Here's another example. See, the liver is taken off the lateral abdominal wall here and rolled across, and we tend to use an L incision because we've learned these things from our hepatobiliary and transplant surgeons. And so here the liver is rolled across, the IVC is exposed right the way up towards the diaphragm, and here's the open cava. And then a graft is put on because you have to in this particular case, we had to excise the cava at that point and then perform a grafting procedure. And the survival rates, they're not as good as T1 and T2 disease, but they're not as bad as T4 disease involving other organs. So it is worth doing your best job for people with this operation. But there are those people that tend to do badly. Elderly people, comorbid people, people who've got systemic symptoms, people who've got abnormal liver function tests, or if you're going on bypass. The 30-day mortality can be quite high, actually, depending on where you are. And even in high-volume centers, it's quite high, 1 in 10. What an interesting figure, right? This is from this study here from Abel et al. In 2014. 75% of deaths occur in the surgeon's first 2 cases. So if you haven't done any of these and you want to do it, just think about that. It's why we tend to do these things as a team. That we've always got a senior surgeon and a junior surgeon, or 2 juniors. There are people involved in these operations. You cannot do these by yourself and expect always 100% excellent results. And these are some of the favorite ones: the intracardiac renal tumor surgery. This is great because you get to watch very high-quality cardiac surgeons operating. And they always teach you. They even teach you how to throw knots again and make you feel like a medical student once again. But it's worth doing these tumors. This is an example of a huge tumor in a polycystic kidney, and you've got tumor thrombus going all the way up, and this is the knuckle sitting in the atrium. Here is the excised cava here, and this is bland thrombus that goes down the iliacs, and that's just everything reconstructed here. And what have we learned from the cardiac tumor practice? Bad prognostic signs are if their liver function has gone off. If their liver is affected, they tend to do bad. The liver function is affected, they tend to do badly. If they're throwing off pulmonary emboli, these are people who are in a very, very precarious situation because even handling the tumor can throw off an embolus. And if their INR is off, they have a mortality rate that's quite well in excess of 10%. So they need their clotting corrected. And here's just an example. This is a courtesy of our cardiac surgeon, Mr. O'Brien, Tim O'Brien, who's also one of my colleagues at Guy's Hospital. And these are some of the things that can go wrong during these surgery. In this particular cardiac operation, we're manipulating the tumor. Suddenly the blood pressure drops to 30 systolic. The patient becomes profoundly hypotensive, and we're thinking, what on earth is going on? So they go on to bypass as an emergency. I don't know if I can play this video. There you go. They go on to bypass as an emergency. We open the right pulmonary artery, and then we pull out tumor thrombus, which is flicked off, gone into the heart, and cause a huge pulmonary embolus. So there you go. There's the heart, that's the chest open, there's the abdomen open, and this is a huge pulmonary embolus that's being pulled out. And you need people to do that. If that happens and you don't have cardiac support and you think it's just a level 1 or level 2 thrombus, and that happens, the patient is dead. What about the robot? Well, yeah, actually the robot is being increasingly used in advanced renal cancer surgery. It's a natural progression. I mean, there's no obvious benefit when you compare it to pure laparoscopy and these things, but there's very promising results. And of course, as people get better and better and better with their robotic partials and robotic radicals, this is only the natural next stage of evolution in treatment. And we know that laparoscopy and robotics is safe. There's no evidence of real tumor seeding from the laparoscopic procedure itself, as evidenced by this article. And so more and more people are doing it. And here we go. This is Inda Bagil's group, who they'll do anything. And this is an example of intracardiac surgery being done robotically. So everything, there are lots of papers saying yes, robots are feasible. So this is an example of a level 1 thrombus that I did. So here we have it. If you see, this is the tumor thrombus, the kidney's up in the air. This is the cava that's clamped. The cava is clamped above and below the tumor thrombus. I'll just show you with my scissors, that's the lumbar vein going in there, which I've side clipped with a robotic WEC applier. And then there you have the cava clamped above and below, left renal vein clamped. These work. These are quite good if you are going to progress into these tumors. The only way to do it is to pick small renal tumors with level 1 thrombi as your starting point in relatively thin patients. Otherwise, you're never going to get there's serious potential for disaster if it all goes wrong. And obviously, have some experience in open surgery before you start jumping onto these. Otherwise, you might find yourself in trouble or getting yourself stuck.
One minute.
Yeah, no problem. I'll race through the rest. Is there a role for partial nephrectomy? Yes, there is. You just have to pick your tumors well, and you've got to pick your patients well. If there's an imperative need, then of course you can do it. Do you need to take the adrenal gland? Well, yeah, there are risk factors, as you know, but more and more we're avoiding taking the adrenal gland unnecessarily. Usually, if I'm dealing with a T3, T4 tumor in this kind of practice that's being referred, we take the adrenal. We tend not to want to leave residual disease. You don't want to be fighting that battle again. So if they have a normal contradrenal, yes, we tend to do it. Does it make a difference? Well, yeah, it does. But it is classified as T4 disease, and routine adrenalectomy doesn't improve cancer-specific survival, but it does depend what you're doing on a case-by-case basis. And the same thing goes for lymph nodes. Lymph nodes, the evidence suggests that extended node dissection isn't really going to be therapeutic for patients, but it may be beneficial for locally advanced T3 or T4 disease with unfavorable histology. Again, there's no randomized controlled trial. You can see some sort of trials suggesting minor improvements here or there. It depends what your disease is. Certainly for chromophobe renal cell carcinomas, we do, because they do recur in lymph node disease and they recur indolently, and therefore it's worth taking. And the next thing, I've only got 2 last points really to make. What's the future? We've got to decide as a urological community, where are we on cytoreductive radical nephrectomy? With Carmina and Surtime, the 2 trials that showed no significant benefit in cytoreductive nephrectomy, but lots of confounding factors, what do you do? For us, it really just depends on what the patient is like and what the tumor burden is like. If they've got small volume lung metastases in a very fit patient, then and the largest burden of tumor is in the kidney, cytoreductive nephrectomy is not the wrong thing. It is very perfectly acceptable. If you have big cannonball metastases in your lung, if you've got liver metastases, bone metastases, these are poor prognostic factors. They tend to do badly. They need the drugs. So they should go towards IO treatment. And the surgery, you'll see, will come as these drugs get better and as survival gets better. We are now seeing more and more cytoreductive nephrectomies being done in the post-IO phase. So people who've had treatment, they've got residual huge kidney tumor, everything else is melted away. Now what do? You try and get a normal scan and you do the nephrectomy, and it becomes much more difficult. So you need to, whoever's doing radical nephrectomies nowadays need to be prepared for difficult nephrectomies that are about to come. And always follow up your treatment by following the evidence. The evidence now is that adjuvant pembrolizumab after nephrectomy high-risk renal cell cancer is beneficial. Okay, it does improve survival. It's only one trial. All the other trials have failed to show it, but it seems to be a practice-changing trial at the moment. So if it is available for the right patient, please do offer it. And my very last extra tip, for 1 second. It's a team sport. These things can't be done by myself or just by one person. You've got to involve other renal surgeons and other urologists with an interest in kidney cancer. You've got to involve cardiac surgeons. That's gone lost at the top there. And we also involve our hepatobiliary surgeons in these cases. If you work with the same team again, your results only get better, better, better. Thank you very much.